Tian, maybe the big picture before we jump into systemic therapy, in the way you manage your patient with metastatic non-clear cell RCC. Is there a role for cytoreductive nephrectomy? How do you treat oligometastatic disease? Is there any specificity related to non-clear cell?
Yeah, so it's a great question, Laurence. And when I think about these patients coming into our clinics, I really do drill down to the subtype. So I'm not a lumper, and so I think about papillary a bit differently than chromophobe, than translocation type. And so the way we think about it in terms of the cytoreductive nephrectomy or the oligometastatic question is, how much is my systemic therapy going to help this patient? And we'll talk a lot about these therapeutic that have developed over the last 20 years. But in subtypes where our systemic treatments may not be very viable, maybe those patients are good candidates for upfront nephrectomy if that's the bulk of their tumor. And then the patients who have oligometastases, if they have only a couple of metastatic sites, then if our systemic therapy is not so good, then maybe we try some localized treatments like surgery, like radiation, before we tackle the systemic treatments and the side effects.
Okay, got it. And it may be different from one tumor type compared to another one. You may not see the same way a papillary RCC than a collecting duct carcinoma we'll be discussing later on, I guess. Okay, so 2 decades, you say, of advances we've used to treat them in the same way we are treating clear cell RCC. So what have been achieved over the past 2 decades?
Sure. So the historic trials, I'm sure we remember, are the ones that really lumped all of these histologies together. And so ESPN, ASPEN, these were trials that compared sunitinib versus everolimus in the frontline setting for these folks. Really, sunitinib came out on top for most of the histologies. Everolimus had a little bit of a signal for chromophobe histologies, but overall low objective responses, and the progression-free survivals were quite short. There was a single-agent pembrolizumab trial for non-clear cell RCC, again a basket trial of all the histologies, and that showed about a 26% response rate across all the histologies. So there's some data, right? The building blocks of combination trials is single-agent trials, and so there's data there for single-agent pembrolizumab. And then as we got more into the mid-20 teens, we started doing more histology-driven subtypes, and these trials like PAPMET and SAVOIR really drilled down to papillary kidney cancer. And so PAPMET was a trial that we ran here in the US in the NCTN cooperative group setting. It was initially started with 4 treatment cohorts, and it finished because crizotinib and savolitinib met some futility midway through the trial. So it finished as a 2-arm trial with cabozantinib versus sunitinib in papillary kidney cancers. And in those patients, cabozantinib showed an improvement in progression-free survival, 9 months compared to about 5.6 months for sunitinib. And so that's where our best data, I would say, for single-agent cabozantinib came from PAPMET. Now, the SAVOIR trial took that a step further. So not only was it histology selected for papillary kidney cancers, but it also drilled down to MET selection. And so as you know, you ran the trial, that SAVOIR looked at savolitinib versus sunitinib, and did not show it statistically significant, but maybe a signal. 7 months progression-free survival for savolitinib versus 5.4 months for sunitinib. And so that really drills down into subtypes and also molecularly driven subtypes. And so if MET is the oncogene that's turned on and can be inhibited, is a pure MET inhibitor the best option for these patients, right? So that's where the clinical development of savolitinib has led into that single agent small cohort of patients, but there's a little bit of a signal there.
Thank you. So for a long time, we had basically single agent TKI across the non-clear cell, with, you said, a response rate that it was in a range of 20%, sometimes even less. Then median PFS around 6 months. Cabozantinib, being the outlier for papillary, changed the guidelines within papillary thanks to PAPMET study.